The leader has muted your line. To unmute your line, press #6.
Nancy Kelly from the New England QIN-QIO, and I'll be your moderator for today's webinar. Session 4, Communication Tools, Stop and Watch, SBAR Quality Improvement, PDSA Cycles. Today's speakers are Carol Dietz, Sheila Eckenrode, and Florence Johnson. Before we begin today's program, though, I'd like to just cover a few housekeeping items. This call will be recorded for training purposes, and we'll give you details at the end of today's session on where you can access this recording. Our phone lines are currently on mute for the duration of this presentation. We'd also appreciate, too, for those of you who are listening, if you can not put us on hold, because we hear a lot of background music, and it's hard to speak over that. And also, we will be taking questions at the end of the presentation today, and we'll provide you instructions on how you can ask a question either over the phone, or you can use our chat box to ask your question. When you are using the chat box, please be sure to send your questions to all attendees. So at this time, I'd like to introduce Carol Dietz. Carol?
Thank you, Nancy. Good afternoon, everyone. What a beautiful day we're having, and what a great day to have an Interact webinar session. So before I introduce Florence to talk about one of the two most important tools of the toolbox, which is Stop and Watch and SBAR, I want to talk about the requirements for the participation agreement. I'm just trying to, okay. So, again, we try to make sure that we talk about this every session, so this is not going to be a surprise for everyone. And your facility is interested, obviously, for you to be on this important webinar series in order to get a participation certificate. Many of the hospitals now are looking for this certificate. So it's important for you to realize what the requirements are. So the first one is, which is not listed right here, but your facility had to sign a participation agreement. The deadline was April 15th, but and with that participation agreement, we now track your participation in the webinars, which you have to attend at least 7 out of the 9 webinars in order to receive our certificate. That's one of the requirements. 2 of them may be viewed online, which means if you happen to miss a webinar, you can go onto our website, which our next slide will have our website link, which is for the New England QIN-QIO, and download the recording and listen to it. And once you download it, you have to register to get into the site, and that's how we track your participation. But as I mentioned, only 2 of the webinars are to be viewed online. We have found that in order to really embrace this work, this quality improvement work, you have to participate live, and you have to share with others your challenges as well as your successes so everyone can learn. So that's why this requirement is in place. The second requirement is that you have to send Qualidigm at least 4 months worth of readmission data. Now, the best place to submit your data is into the NHQI campaign website, and we had a speaker talk about this 2 months ago, and by signing the data use agreement with Qualidigm, that allows us to look at your data. That's all we do is look at it. We don't do anything else with it. Unless you and us go into it together, and we can talk about your reports and talk about what it is the data is showing. But we have to have at least 4 months worth of data, because what we find is once you do that 4th month, you will continue on with the 5th and the 6th and the 7th, because you are going to gather so much information out of these data reports that you're going to find it so useful. The other requirement is that at the very end of the sessions, your nursing home administrator is going to complete the Interact tool checklist to verify the tools that you have in place. Now, we are not looking for this check every box. What we're looking for is where are you at the time of the last session. So therefore, we know where else you need to go so we can help you continue on your journey, We don't expect every box to be checked off. So those are the requirements. Now, as I mentioned, if you do miss a session, you can go online to the healthcarefornewengland.org website, and our website link is right there. And you will ask to fill out your name. Once you click on the events tab, you're going to scroll down. So once you get to the landing page, you're going to get on the website, get on the landing page, you're going to see an events tab. Then you're going to click on that, you're going to scroll down to the previous events link, and you're going to click on the month to find the session that you missed, and then click on the webinar recording link. Once you click on that recording link, you're going to be asked for your name. Please make sure you put your nursing home name in there. That's how we track your facility participation. That's really important. Your name is important, but also where you work. And that's how Julie tracks all our nursing homes. Now, these are the dates of our previous sessions. And again, each session we will make sure this is added so you can have a nice calendar in front of you in case you did miss a session. So today's session, these are the objectives for the day: to understand the Plan, Do, Study, Act process. Sheila is going to be discussing this. And then Florence is going to be talking about understanding how to use the Stop and Watch tool, understand how to use the SBAR tool and improve communications, which will improve communications between caregivers, and then to start developing a plan of implementation, because it doesn't happen overnight. That your team, your implementation team, needs to sit down and decide what unit, what patient, what nurse is going to start using these tools. And then you're going to debrief after that and then start tweaking it so it fits into your culture. So, again, I'm going to turn this over now to Florence to start talking about the two tools for the day.
Thank you, Carol. And I have to piggyback on what Carol has just said to you, that in all the work that we're doing with this Interact program and education, it truly is about culture change. It's not about checking boxes to say that you've done something. We want the culture in your facility to change. That's the only way you are going to affect any type of quality improvement. Today we're going to discuss two very important tools, and these two tools, when facilities that were in the original studies used these two tools, they were able to decrease their readmission rate by 50%. Which goes to show that at the very bottom and at the very base of the work that we do, it's about communication, how you talk to people and get the change that you want to have occur. Remember that implementation can take up to a year. We're not expecting you to Interact within 30 days or 6 months. To truly have your change have feet and grow roots, it's going to take about a year, and you're going to have a lot of bumps in the road. We don't want you to give up. Just remember that we're here to help you and support you through this. So today we're looking at communication that occurs within your facilities. And one of the first things that we want to talk about is Stop and Watch. Okay, so Stop and Watch. This was originally developed with CNAs in mind. But as time has gone on, again, Interact every year looks at the buildings that are using the tools, so they still actually have a team that looks at what people are doing out there. So they take the feedback that they're receiving from facilities and they try to improve upon each of their tools. So Stop and Watch initially was developed for CNAs. It's an early warning tool. It's a way for CNAs to communicate with nursing. It communicates change in conditions, subtle changes that we ordinarily may think, oh, it's no big deal, but when you look at it and you catch it early enough, it's able to prevent a not such a big deal from becoming an emergent situation. And it efficiently brings together all pertinent information that the CNA or the non-clinician needs to communicate to the nurse. So as I said, it was designed for CNAs, and as time went on, they realized that all non-clinical staff can actually use the Stop and Watch. So your maintenance people, your housekeepers, your dietitian, your rehab assistants, your secretary at the front desk who sees your residents as they go in and out every day, your families who spend a lot of time with their family member in the facility, they spend time with them outside of the facility. It's very important that when family members are visiting that you involve them in this being an extra set of eyes for you. And sometimes when they have their family members out, something may occur while they're out and they don't even think about it by the time they get back into the building. So if you give them one of these Stop and Watch tools, they'll be able to come back and communicate any changes they have seen. Now, remember when we educate, we're truly just educating you on a particular tool. We are not giving you the process of how it should work. The one thing that you do with your Interact team is to get together and talk about how do we want this to look in our building. Because your building actually has a different flavor than nursing home B. So we can help you to build your process, but we can't educate on a particular process because it's all very individualized. So once you decide that you're going to implement Stop and Watch, you need to have a process in place, and it begins way before the tool even gets into the building. It's looking at who's going to order it, where is it going to be stocked, when it runs out, how should staff get a hold of more, the accessibility of it, how are you going to even inform your families and your residents that this program is going on. So there's a lot of pre-work before the tool even gets into the building. Please do not start a program without having a process in place. Please do not start a program without having a process in place. You're setting yourself up for failure. Do not do it. Do not have a process in place without educating your staff. They need to know what their roles and responsibilities are. They need to know what your expectations are for this implementation. Again, it all boils down to communication. And then once you started to educate your staff, it's not just only important to educate the CNAs or the non-clinical staff. You have to also educate the nurses who will be receiving these tools to know their role in this, because it's very important that they acknowledge that tool and they listen when someone is giving it to them. Listen as in take it and read it and do something about it. Okay, so this is what the Stop and Watch tool looks like. When you're working with the Stop and Watch tool, it should be in NCR form, so it's carbon copied. Please do not make a copy of this in an 8 by 11 piece of paper. That kind of defeats the whole purpose. It's a tool that should fit into someone's pocket so that it's easy to carry. And the reason why you want to make it NCR is that the white copy goes to the nurse, and then the nurse reacts to it, and once they're done reacting to it, that white copy makes its way to the supervisor and then makes its way to the morning report so that it can be discussed as part of your morning report. Now, there are two schools of thought about what to do with the yellow copy. Initially, it was designed for the person that's giving it to have as a receipt that they actually communicated a change. Some buildings have chosen to have a Stop and Watch receipt box so that the yellow copy then goes into the box and they're able to reconcile having a yellow copy in the box and a white copy at morning report, because you want to make sure that anything that's being reported is really being dealt with. And some facilities who have point-click care do have these documents electronically. My concern with the electronic version of the Stop and Watch is that once the nurse clicks on it, it goes away. So now how do you, as team members, go back and look at what was given to the nurse in an electronic version and make sure that it's discussed and followed up with? Again, that's a process that you're going to have to develop yourself. So I have a polling question because I love polling questions. Are you currently using the Stop and Watch tool in your facility? And that could be electronic or hard copy. Emily, could you open that for us, please? And once you've made your choice, just hit submit so that we will get your responses. Oh, there it is. Yes. Everybody can do it now. So while we're waiting for you to make your choices, and don't forget to hit submit when you're done, please remember that it's important that once a Stop and Watch tool is given to a nurse and you've resolved the problem or the issue, it's important that you come back to the person who gave the Stop and Watch to let them know exactly how the situation was dealt with. It, one, closes the loop, and two, it empowers the person to continue to use the Stop and Watch because it's not just a waste of effort for them. Okay, I will move on. I'm not sure what's going on with the...
There you go.
Oh, there it is.
Yeah.
Okay. So 10 out of 25 still aren't using it. And those of you who didn't answer, I'm sure you just didn't get to the question. Well, hopefully after today, we'll have 25 out of 25 using the Stop and Watch tool. It's really a wonderful tool in that it catches, honestly, nuances early on before it gets to an emergent situation. So, as I told you before, it's for CNAs, rehab therapists, dietary staff, housekeeping, activities, laundry, those people who spend a lot of time with your residents. And also, the Stop and Watch tool is used especially at times when the nurse is administering meds and you don't want them to be interrupted. When should you use it? It should be used during the shift any time that a change occurs. Usually during personal care, you'll see a lot of skin issues. During ambulation is when you'll see any type of swelling. So at those particular times is when it really comes in handy. Again, and when you have family members that are taking their resident out. So what could be a barrier to the success of implementing Stop and Watch? Inconsistent assignment. It's important that your CNAs know their residents. So if you're changing their schedule every day, it's really hard to get to know someone if you're seeing somebody different every day. Consistent assignment is wonderful. It builds a lot of trust between the resident and the staff. And you become like family, so you know that person, you do know their nuances. Of course, staff turnover, which is just part of living the SNF world. Broken relationships and communication between nurse and CNA and CNA and CNA. So as leaders in your facility, it's important that we encourage proper communication. When on duty, it's all about the resident and the patient, and we have to model the type of communication that we want our staff to engage in. Another barrier is resistance to change. A lot of times people say it's so much easier to just tell somebody versus putting something on paper. if you notice that the stop and watch is really all about circling, you're not really writing a dissertation. You just circle the symptoms that they're seeing. So if you want to use stop and watch by itself, it's almost pointless because it's part of a comprehensive program. So you can't really use Interact stop and watch just by itself. It should be part of your full Interact implementation. And then lack of leadership from a clinical champion or the unit nurse. So the unit nurse that sees no value in it and devalues the whole program. So it's important that leadership has buy-in and supports this program. So I have another polling question for you before we move on to the next tool. Have you implemented the SBAR tool in your facility? Again, this is on paper or electronically. If you can open the poll for me, please.
There you go.
Oh, wonderful. Don't forget to hit submit when you're done. I'll take a breath. I will tell you a quick story while we're waiting. I was on a national call a few years ago when we first started doing Interact, and there was a doctor on the call that was telling us about the importance of the SBAR tool, and he said that a nurse had called to give him a report, and he could tell by this organization of the report that she had not used her SBAR, and he told her to hang up the phone, fill out an SBAR, and call me back. That's what I would love Connecticut to get to. Yes. Ooh, 19 out of 25 are using the SBAR tool. That is awesome. That's great. Yeah. All right. So maybe we will get there. Now we just have to get the doctor to have an ear for it. Okay, so I'm almost preaching to the choir if 19 of you are already using the SBAR tool. It's a nursing communication tool. It's a tool that communicates changing conditions. It's a way to speak from clinician to clinician. It actually helps you gather your thoughts, gather all the data that you need before you contact the physician. So the purpose of the SBAR is to improve communication. It's a way to have consistent language across the board. It's a standardized way of talking. It has clear guidelines. The communication is efficient, and you can probably give report in less of a time than if you were scattered and didn't have all your information in front of you. And those of you who have PCC, the SBAR is built into your EHR, and I believe in PCC it's able to maybe do it in 1 or 2 pages versus if you're doing it on paper and it's 4 pages. Yes, I know people say, but that's a lot of pages to go through. Remember that there's very little writing, again, when it comes to the documents in Interact. They've tried to get as many diagnoses as possible on there, so you just have to circle on. Basically what you have to write is your assessment. So the first page just talks about the S and the B, which stands for situation and background. So situation, why are you having the need to call the doctor? And then the background is your vitals. If this has happened before, what did you do about it? How were you able to resolve it? And it breaks it down by systems. So your evaluation. If it's a respiratory problem, you want to fill out the respiratory area. If it's cardiac, you want to fill out the cardiac area. So although it's 4 pages, if you're only focused in one area, that's the only area you fill in. You don't have to do a head to toe. And then at the very bottom of the background, it asks you about advanced care planning, which is a good thing to keep in mind when you're having to call a doctor. And then page 4 looks at what does your resident look like right now to you? So just giving a description of what that person presents like. Are they cyanotic and their toes are mottled, that kind of thing. And then the R is the most important part of this whole document, if you ask me. It talks about review and notify. So you want to tell the doctor what you're calling them for. You're not giving them orders. You're basically being a team member and kind of guiding the result of what you want. So if you're calling to just notify them, you say that. I'm not really looking to transfer this person to the emergency room. I'd like to keep them here and maybe start an IV and, so guide the physicians, especially if you're contacting an on-call who doesn't know your resident. Because they have two toolboxes two tools in their toolbox. A prescription, and then a prescription pad, and then a telephone that says you take them to the ER. So you want to keep your residents in facility as much as possible. All right, so I will now turn it over to Ms. Sheila.
Thank you, Florence. I'd like to talk to you a little bit today about PDSA cycles, sometimes called PDCA cycles as well. Plan, Do, Study, Act. And you might have heard of these, and if you have, I just would like to take a few minutes to talk to you about how you can use them to implement new processes in your facility. As Florence said, we really can't introduce these tools until there's a process in place within your facility and within your culture that can accept them. And PDSA cycles are a really good way to introduce new things. So basically, it's plan, do, study, act. You're planning an intervention, trying the intervention on a small scale, studying the results of the small-scale intervention, which just means did it work or did it not, and then if it didn't work, you're going to try something new. And this is part of the scientific process. It certainly is part of the nursing process. If you work clinically, you use this all the time. Say you have a patient who you believe to be dehydrated, that's your hypothesis. You leave a container of water in their room. Come back and the water's untouched. There's your study piece. Act. Well, next time you're going to hand them a popsicle. Do something different. So we do these iterations all the time. If you've ever had a small child or an infant that was crying, you know this route, right, Jules? You'll try one thing, then another thing, and the feedback is whether or not the baby starts crying. So we use this in our life, but often when we plan system-wide change, we go from do to act. So we try something, and then anecdotally or we get a feel that it's not working, and we either reject it and say this doesn't work here in our facility, or we just try something different without really studying whether or not it did act. So those of us who kind of deal in the world of data and statistics talk about noise and signal, and that's the study piece. You want to look at what you've done and measure something so you can tell whether or not there's really a change. So let's walk through this when we talk about implementation of Interact tools. So, the planning part, we always start with a hypothesis. You might say to yourself, I think we can implement Stop and Watch on West Unit. Inherent in PDS cycles is their size, that they should be small and kind of tight. And this works for a lot of different reasons. One is that you can choose the unit that you feel will be receptive. So you're sowing your seeds in fertile soil. Another is, if it doesn't work, it doesn't become this large-scale disaster that everyone, mourns. It's just one small intervention that can be tweaked. So it always starts with a hypothesis. You're thinking, I wonder if this will work. I wonder where I can do this. That's the plan part. Pretty simple stuff. And then comes the do part. So ideally, before you do or start your implementation, you're going to gather the end users. So you're going to gather some CNAs, maybe a housekeeper that seems interested in these new processes and is alert and resident-centered, nurse, maybe a nursing supervisor, and you're going to brainstorm some things. So the do part, we're going to implement Stop and Watch. we're going to ask staff development to present it at a staff meeting. Well, that's a real small part of it, right? Staff development's always presenting something at a staff meeting, and very often that's where it stops. So we want more than that. So we're going to order the pads, as Florence said, and keep them in the nurse's station, and maybe we're going to put them in the break room for the CNAs to use and for direct care staff to use. The charge nurse will begin to ask CNAs if they have any stop and watch slips at the end of shift sign-off. So if your charge nurses have a process and a way of signing off at report, you want to build in a prompt there where they're also asking, as the aides come and kind of leave the building, they're asking, do you have a stop and watch for me? The nurses in report are asking each other, any stop and watches this shift. It seems pretty small stuff, but we know how difficult these changes are. It's really difficult to get people to do something different, especially when they're busy. So we want to kind of hardwire it a bit, right? Ask the shift supervisor as they walk around with whatever type of clipboard or prompt they have to take facility-wide report to ask if there's any stop and watches. So these are the things that this group, my hypothetical group on West Unit, have come up with. As Florence was talking about closing the loop, some other things they might try is bringing the stop and watch slips to morning report. Assigning the shift supervisor the responsibility of bringing the plan back to the unit nurse and CNA. Sorry for that typo. Word always wants to make CNAs can do CNAs. And the stop and watch slips will be shared with APRNs and MDs that come to evaluate the residents. So these are things that might work for your unit, but maybe not. You know, we're working through this hypothetical PDSA cycle. So just to recap this thus far, it begins with a plan. A plan is just a hypothesis. It's an idea. You want to assemble a group of people together because more brains are better than one brain and certainly better than no brain. So you want to get as much brain trust in the room as you can. Come up with some ideas and try them. Okay, so we try them. And then what? This is the part that people find it hardest to accomplish, and that's the study piece. We have to design these new initiatives with some sort of metric in place, or we'll never know whether or not they're working. So for stop and watch, some of the things you might try are how many slips are turned in. If you roll this whole thing out and you've educated people and you've left the slips here and you've hardwired the process and no slips show up, it's not working, right? How about the number of stop and watch slips that resulted in a change in a resident care plan? That would be another really good metric to look at with stop and watch. And we're not talking about grand data collection with Excel spreadsheets and computers. We're talking about counting things like your fingers and toes. You know, having a basket where you drop the slips at the end of the week and have somebody just count them up and see. Staff feedback. Are people saying that this works, that they're liking it, that it makes sense to them, or are people saying that this is miserable and this isn't working at all? And then we have what we call outcome measures or metrics. Unplanned readmissions and ED visits, the big thing that we're trying to prevent. So there's two ways of measuring a new process. One is what we call process measures. That's just, you're measuring the implementation, the spread, whether or not it's happening. That's important. And the second one is what we often call outcome measures, and that's what you're trying to accomplish at the end of the day, things like unplanned readmissions and ED visits. So you study it, and you see if it's working, if it's taking, if people are using this tool, are readmissions going down. The last piece of it is act, because if it's not working, you don't have to throw it away. We can tweak it, and that's another piece where it's difficult to get busy clinicians to try this, because I'm sure as you round from your facility after implementing new initiatives, you hear people say, oh, this doesn't work, it never works. Well, it doesn't work in its current form. So at that point, we as change agents need to kind of challenge the people that we work with and say, well, what do we try next? What might work? And that takes the whole cycle back again. It's a new hypothesis. So maybe they'll say, you know what, the stop and watch pad thing in the nurse's station isn't working. CNAs may say, I want to carry it in my pocket. So we're back to a new hypothesis. If we have it in our pockets, we'll use it more often. You might hear, well, the information gets diluted by the time it gets to the MDs. Somebody might suggest, well, let's make sure that the actual slips are there when the MD and APRN comes in. And if it works, and I know it will, I have confidence in that, the next thing to do is roll it out to other staff. So when we think about plan, do, study, act cycles, we're thinking about small cycles of change. And the study part, I can't stress enough, because we need to know that it's actually taking place, and we need to differentiate what we signal from noise, if you will. You know, what we think is happening from what is actually happening. So I could say, you know, on the DNS, and I said it to everyone, okay, we're going to implement stop and watch, and you're going to use this tool, and then I'll turn around to my administrator and my corporate parent and say, yeah, we use stop and watch, and only to find out that not one slip has ever been turned in. So what we think is happening and what's happening, there could be quite a disconnect. So I encourage you to try to use PDSA as you implement these tools. As I said, it's not something unfamiliar to clinicians. It's part of the scientific method, and it's something that's pretty intuitive. People understand it. We tried it one way, it didn't work. We're going to try it again. That's really the message, that we're tweaking this tool, we're tweaking this process to fit us, to fit our culture, to work for us. And that's a respectful way of introducing any new tool. So I hope you use PDSA in the future. If you want to know more about it, please contact me. It's something I believe strongly in, and I've seen it work in a lot of different places and a lot of different problems. I've been addressed successfully. So that's my pitch. That's my story. And I've got one more slide. Oh, all right. I didn't even know that. All right, one more slide. What are we trying to accomplish in using PDSA? What changes can we make that will result in an improvement? And how will we know that change is an improvement? We know that by the study piece. And now I'm going to turn this over to Kara.
Can I just quickly piggyback something that Sheila said? Once you've implemented the stop and watch, a nurse should not take verbal change in condition from anyone. There needs to be a line drawn that today is the last day we're going to do this. So moving forward, reports should only be given using the stop and watch. Do not allow people to fall back to what they're comfortable doing again. Thank you.
Great. That's a great recommendation. Thanks, Florence. So this is Carol again. I'm going to finish up the session by going over the homework that was given out last month. So we can, this is one of the most important times of our sessions, that we're sharing with each other the barriers, the challenges, and the successes, so we can learn from each other. So last month, we had a guest speaker, Margie Giuliotto, who talked about the medication reconciliation form. So the homework for this past month was the team leader was supposed to download the medication reconciliation tool from the Interact website, save it to a shared drive on the facility computer, and then make copies of the tool for the team to review. So then during your team meeting, you're supposed to review the MedRec tool, what would work, how is it going to work for our facility, and then discuss how and when the staff, nurses, the supervisors, and the leadership, including the medical director, will be educated on the use of the tool. Also during this meeting with your team, you were to decide which unit will begin to use the MedRec tool with a new admission. And as Sheila just said, you always want to start small. Anytime you have a new intervention you're trying to implement, once you get that education done, you're going to start small, do a PDSA cycle, and then debrief. You want to talk with that nurse who's using that tool or use that tool to see, hey, how did it go? What worked? What didn't work? What were your barriers, your challenges? What did work? And then tweak the tool or tweak the process, and then do another one. Do another new admission with maybe even the same nurse or a different nurse. But you want to start small and then spread. And once you've tweaked it to a point where 3 or 4 nurses are saying this is working really well, that's when you start to spread. And also during this team meeting, you're going to develop a timeline of implementation. And again, included in the plan, you're going to debrief with every time the tool is used for the first time with a new staff member to see how things went. So that was the homework. So now we'd like to open up the line so we can start sharing with each other to talk about any lessons learned, successes or barriers that you want to share when you developed your process for educating your staff on the new Interact tool and the implementation of the tool. And how did it go the first time? How did it go when you met with your team after they used it for the first time? And how did things go when you talked to your leadership and medical director about this new MedRec tool? So Nancy, if you can let everyone know how to open up the line.
Sure. So if you'd like to make a comment, just please press #6 to unmute your line. And also feel free to add a comment in the chat box as well. You'll see that on the right of your screen. You may need to select the arrow down to kind of open up that box here for you, but you can also place a comment in there if you'd like. And once again, the phone command is #6.
So if no one jumps on, Florence is going to do a call out, a shout out. So you better start using that #6. Let us know. This is a really important tool. My mom just came out of a nursing home, not in Connecticut, in another state. And there was 2 med errors that I picked up on, and I wish they had that MedRec tool. They were an Interact nursing home, believe it or not, at least that's what they told me. I didn't see any stop and watch. I didn't see SBAR. However, they knew what Interact was, so that was sort of good. Needless to say, I had a chit-chat with the nursing director before I left about Interact. So again, #6. To open up your lines and let us know how things went with the MedRec tool, the implementation of the MedRec tool.
Hello?
Hi.
Hi, it's Melanie from Cassena Care.
Just about to Melanie. Yes. Okay.
We actually, most of the tools are embedded in our electronic medical record, and I do want to agree with what you were stating about the clinical alerts or the SFAR, not the SFAR, yes, stop and watch. Our stop and watch is more so comes up as a clinical alert, where if the CNA documents something, it'll come up as a clinical alert. And prior to actually deleting that clinical alert, we have to make sure to follow the care path. Now, luckily we didn't have any bad outcomes, but we almost did have some bad outcomes because the clinical alert was deleted prior to deleting the clinical alert off of the dashboard. That's one thing I want to say. And something else that I wanted to say, we also have a process that we call equality that also monitors every clinical aspect in points of care, so they monitor those readmissions and new admissions when they arrive to our facility, and they look at the med reconciliations as well. So when I downloaded the form and actually compared it to what equality had found out on their audit tool, it was good because if I wasn't doing a morning report, before we can get the equality tool and say, well, this med was missed, or this care plan wasn't added, and this wasn't done. I was already identifying what was wrong with the actual admission or readmission prior to morning report. In that aspect, it was good. As far as the medical director, we haven't got to him yet because we are transitioning to a new medical director, and now is currently on vacation. He'll be back soon. But the team, they're okay with the tool. They look like if it works in nursing, anything that's going to strengthen clinical, they're all for it. So.
Great. Excellent. Thank you. Thanks for that feedback.
You're welcome. Hello?
Hi.
Okay. Commute again is star 6.
Commute, yes. Star 6.
I think it's star 6 is to mute yourself.
Thank you. So anyone else want to share how the MedRec process went? Could you talk to us about your process of educating the staff, implementing it for the first new admission coming in? How did it go? Anybody want to walk us through that?
Janice, are you on?
Janice. Yeah, I'm right here.
Hey, Janice.
Hi, how you doing?
Very good. So can you tell us how it's worked?
Right now we're I'll talk to you about what we're doing. Actually, I'm just in the infancy process. Doing a policy and procedure, a workflow map that I'm going to put to the staff. As far as medical director and the medical staff, we have a medical staff meeting coming up in another week, so I plan to review all of that with them at that time. And right now with the director of nursing and the AD&S, we're taking a look at the form. So I haven't implemented the form. I'm putting the policy and procedure together and kind of laying the groundwork.
Great. Excellent. Thank you. That sounds like a good way of laying that groundwork. And as Florence mentioned at the very beginning, getting all these tools in is going to take over a year. Even though we're doing these sessions in 9 months, it doesn't mean that you're going to get all of these tools in 9 months. It takes time. You do one at a time or what you can do is do one tool in one unit and start another tool in another unit. But again, you have to keep track, doing those PDSA cycles and monitoring how are they doing not to overwhelm your staff or overwhelm yourself. So that Excellent. Thanks, Janice.
Thank you for volunteering.
Anyone else?
Can anyone answer this? Has the MedRec tool been found useful? Have you found errors?
Donna Sango, are you on? Pound 6 to unmute yourself.
Oh. Hi. Donna, is that you?
All right, while we're waiting for Donna to figure out how to unmute herself, I have to stress the importance of really starting small, like Carol said, and starting with one unit, refining the tool, refining the process, and as you succeed on that one unit, you move to the next unit. Please do not try, even if you only have 3 or 4 units in your building, do not try to start on all. You cannot, it's too much to wrap your arms around. You cannot follow the data. You cannot monitor it well enough, and that's how you get fatigued. And then you say, well, the tool didn't work. No, the process was overwhelming. So start small, take your time, and succeed at one thing. Let's see. Marcia, are you on?
So pound 6, please, Marcia.
Hi, yes, I'm on.
Yay, you don't get extra homework. Donna's gonna get extra homework though.
Yay, I'm excited. No extra homework.
So tell us about your process for how you implemented med reconciliation tool.
So we're actually taking baby steps. It's really challenging here for us right now. We're having a lot of staffing issues, and so I'm kind of struggling with the implementation to begin with because of the staffing crisis that we've been under here.
Okay. So what steps have you taken? Has your team actually looked at the tool?
Yeah,
you met with your team?
I've met with the team. We've looked at the tool. We're kind of trying to figure out how to proceed from that point. It's kind of right now. We just implemented point of service for our meals and other changes, and it's kind of like picking and choosing how you want to proceed. Little changes at a time.
Right. That's very healthy. That's a very healthy way to keep your staff healthy and to keep the momentum going.
Right.
And just know that the Interact Med Reconciliation tool, we've gotten feedback that it's not the best tool. So if you have something else out there that's working better for you, we would really love it if you share with us, and then that way we can send it out to people to have options. Because we're not saying that for this particular session, the MedRec tool, we're not totally committed to it. So we want to have the best system possible. We want to have people doing med reconciliation, not just review, reconciliation. So if there's another tool out there that people are just in love with, please share them with us.
Absolutely. Thank you.
Great. Thank you, Marcia. Okay. So for our final couple of slides, you do have homework. Everybody has homework, but Marcia, you don't get the extra homework. So this is about Stop and Watch in SBAR. So the team leader is going to be, for the next month, this is your homework. The team leader will download the Stop and Watch and SBAR tool from the Interact website. And that very first slide that Florence had after the introduction basically showed you what the website, the landing page website looks like once you get onto the website. And then you're going to make copies of each of the tools so the team can review them. Again, you want to go line by line, everybody understand it, what any questions, and talk as a team. And then the team leader is going to be downloading each of the tools to a facility computer on a shared drive so you can have further access to these tools. Then, during your team meeting, you're going to review both of the tools to make sure that the shared mental model, that everyone understands each of the tools. And then you're going to talk about how you're going to educate the staff nurses and the supervisors, the medical director and the APRNs on the SFAR tool, and then your non-clinical staff as well as your clinical staff on the Stop and Watch tool. Again, so because there are two tools, we recommend that you start on one unit, the SBAR tool, and then on another unit, the Stop and Watch. And again, you start small with one patient or that first change of condition using the SBAR tool, and then you're going to debrief with that staff nurse or that the CNA who writes out the Stop and Watch to see how it went and see how the process goes. And then you're going to develop a timeline for further implementation, for the further spread. But again, that happens down the road after you use both these tools a couple of times and it's tweaked to fit your culture, to fit your facility. As I mentioned, you're going to talk with the entire staff about the Stop and Watch tool, as I said, and develop a timeline for implementation. And debrief after each time it's used for the first couple of go-arounds. And also, you should always, when you meet with your team, with your Interact team, should always be looking at your readmission data. I mean, that's how your team meeting should start. How did we do this past month? What do the reports say? And again, if you have any issues looking at your data, please give us a call. That's what we're here for, and we can help you with that. So with that, we're going to open up the lines again to see if anyone has any questions for the three of us. So #6 is to open up the your phone line. So before we end, any generalized questions or immediate issues you'd like to talk about?
Hey, I actually had a question on the stop and watch.
Sure.
Okay, so I know you're saying to kind of do the slowing with implementation, maybe just one unit at a time. But with that one, isn't it kind of difficult as far as if it is to involve all the departments? You know, you're talking to laundry, housekeeping, dietary. I mean, how would you suggest doing that? Like, you're bringing it up, but then you're saying we're just using it on, say, this one unit?
Because what should happen, and this is Lauren speaking, what should happen is that anyone that works on that particular unit, so you should have one particular maintenance guy, a housekeeping, the 2 or 3 people from food services. So those people, the team that takes care of residents on that unit, we use it for that unit.
Okay. I mean, in our facility, it's like our maintenance guy, our laundry, you know, they're the whole building. We don't really have, you know, other staff that are relegated to to one unit.
And that's fine. Then they will use that stop and watch for that particular unit, and then they'll be ahead of the game when they start getting moved to other units. And they'll be able to go ahead and start championing it for you. They'll be your cheerleader on the other unit. So by the time it gets around, they'll be pros at it.
Okay, thank you.
Yeah.
They can help create some buzz.
Yeah, absolutely.
And they can have kind of like a healthy competition, because then the other units would be like, well, why didn't we get to use it?
Excellent. That was an excellent question. Thank you. Any other questions for the team?
All right, so don't forget that for the stop and watch, it really needs to be carbon copies. You can go onto the website and order it from the website, or if you have a provider locally, say WB Mason or Staples that does your paper goods for you, you can take a copy of it off the website or email it to them and have them produce it for you. So we don't have any skin in the game for whichever way you want to do it.
Okay, so just a couple of announcements before we end today's session. Just a quick reminder that we are on social media, so we encourage you to follow the New England QIN-QIO on Facebook, LinkedIn, and on YouTube. Here you can get updates from us on various training events, both in-person and virtual, announcements, and training tools and resources that we're developing as well. When you close out this webinar, an evaluation will immediately pop up on your computer. If you could please fill that out, we would greatly appreciate it. But if you don't have time now to fill out the evaluation, or if you're sharing a computer with someone else, you'll receive an email tomorrow with a link to the evaluation, as well as a link to the event page on our website. The PowerPoint presentation was sent out in an email you received earlier today with the login details, but you can also access that on our website. It's currently up there now. That link is www.healthcarefornewengland.org. In the events tab, I think we actually have a link to that in the chat box, but it'll also be in the email you receive tomorrow. And then just a quick reminder too, in the next few business days on that same page, on our events page, we will also be adding the recording from today's session as well as the transcript. So thank you all for attending and have a great day.
Bye. Happy 4th.
The reader has disconnected.
The conference will be terminated in 5 minutes.